Hi everyone. Now today we'll be dealing with the management of cataracts in adults. Management of adult cataract, though essentially it is surgical removal. However, certain non-surgical methods may be of help in certain circumstances until surgery is taken up. Non-surgical, we'll be discussing about non-surgical management. So it consists of mainly treatment of the cause of cataract, like example adequate control of diabetes mellitus or removal of cataractogenic drugs if the patient is on them, like corticosteroids or phenothiazones and stronger myotics, and removal of exposure to radiation or infrared radiation, or early and treatment of ocular diseases like uveitis which prevent occurrence of complicated cataract. So treatment of the causative disease many a time may stop the progression, and sometimes in early stages it has proven to even cause regression of the cataractogenesis which have already caused. And other methods to delay progression are um, commercially available preparations containing iodide salts of calcium and potassium, which are being abundantly prescribed now only in case of early stages of cataract to delay the progression. And vitamin E and aspirin also have some role in delaying the progression of cataract. And the third method is measure to improve vision in presence of NCP and cataract. So the most common method is refraction and spectacle prescription, and others is illumination changes, like if the patient with peripheral opacities who has central area free may be instructed to use bright illumination, or hence the pupil will constrict and the patient will be able to see through the center, which is cataract free. Conversely, in case of central opacities, a dull light is kept beside the patient, which leads to dilatation of the pupil, and hence the patient will be able to see through the peripheral part of the lens. And use of mydriatics in case of central cataract, use of phenylephrine and tropicamide can be advised if the patient wants to postpone surgery. But the main line of management in case of cataract is surgical management. So coming to the indications of surgical management, the main reason is visual impairment. This is by far the most common indication for cataract surgery. However, it depends on individual to individual and the individual needs of the person. So an individual should be operated when the patient has significant determinant to maintain his regular lifestyle. And medical indications of cataract is in case of diabetic retinopathy, wherein we need to go ahead with a further treatment, and where the lenticular opacities are interfering with the treatment, and few complications related to cataract, like lens-induced glaucoma, phacoanaphylactic endophthalmitis. So all these need to be operated immediately. And very rarely cosmetic indication, where the patient want to obtain black pupil in spite of nil visual prognosis because of some retinal pathology or something. So we can advise cataract extraction if the patient is willing. um, so next, coming to preoperative evaluation. So this includes both general medical examination as well as ocular examination. So once we have decided to operate the patient, we need to do a general medical examination of the patient, because we need to exclude presence of some serious systemic diseases like diabetes, hypertension, cardiac problem, or any obstructive lung disease, or any potential source of infection in the body. And ocular examination is very vital, which includes basic visual assessments, slit lamp examination, fundus evaluation, intraocular pressure, and so on. So coming to the ocular examination per se, so the first is the retinal function test. In retinal function tests, the main important things are perception of light, projection of rays, tests for Marcus gun pupil or relative afferent pupillary defect in case of mature cataract, when the fundus is not seen. And other macular function tests or retinal function tests are, though these are obsolete now, just for the completion sake, we need to tell, like 2-point discrimination test or 2-light discrimination test, Maddox rod test, color perception, which is important, entopic visualization, laser interferometry, and certain objective tests for evaluating retina like ERG, EOG, VER. These are particularly performed in children where it is difficult to assess the vision. So, coming to perception of light, though many sophisticated retinal function tests have been developed, light perception is very important. If there is to be any potential for useful vision, the patient will be able to perceive the light. So hence it remains a gold standard test for assessment of vision in case of mature cataracts. So, and projection of rays, though it is a crude method, but is an important and easy test for function of the peripheral retina. So it is performed in a semi-dark room, unlike any other pupillary reflex test, with the opposite eye covered, and a beam of light is thrown in the patient's eye from different directions, and the patient is asked to look straight, and he needs to point out the direction of the light. He needs to point out the direction of the light, and it gives us a rough idea about the attachment of retina opposite to the quadrant where light is shown. And next is the 2-point or 2-light discrimination test. So like I told you, which is obsolete now, but still you need to know the name, that's it. And the Maddox rod test, coming to 2-light discrimination test, followed by Maddox rod test. The patient is asked to look at a distance bright light through a Maddox rod, and if you see a red line, it indicates a normal retinal function. Similarly, other tests are color perception, this is a indicator of normal macular function, and entopic visualization. It is done by rubbing a light source over the eyelid. If the patient perceives the retinal vascular pattern, I'll show you the pictures later on, in black outline, it's a favorable indication of normal retinal function. And other tests are laser interferometry. It's a very good test for measuring the macular potential in presence of opaque media. And other objective tests, like I told you, which are done mostly in cases of congenital cataract. So this, to the right corner, it is a entopic visualization. Wherein a light source is rubbed over the lid, and you can see the vascular pattern, tree of vascular pattern. And similarly, the left hand corner, you have the Maddox rod test, wherein the patient is asked to see a light source through the rod, and you can perceive a line. And after retinal function test, you need basically, ideally what we do is a visual acuity assessment, followed by anterior segment evaluation, followed by fundus evaluation, and so on. And but according to the book which is given, they have given retinal function tests prior to the ocular examination, or prior to the anterior segment evaluation. So it depends, however you want, you can write. And search for local source of infection, like if the patient is having any lacrimal abscess or any conjunctival infection. It's very important to rule out, because so it is very important to rule out any local source of infection prior to operation, as they have to be like if the patient is having lacrocystitis, DCT or DCR has to be performed prior, or if the patient is having myometritis and blepharitis, they have to be treated adequately, because they can be a source of infection post surgery. And coming to anterior segment evaluation, like we need to evaluate for the lids to rule out any infections like blepharitis or myometritis. evaluate the conjunctiva, then cornea. Cornea, rule out any keratic precipitates, or to the see for the corneal endothelium, look for any dystrophies, and anterior chamber depth, whether it is deep, shallow, then pupil, whether pupil is dilating after installing mydriatics, or pupil size is normal, pupil shape is normal, and look for any iris abnormalities or any nodules, or the most important is lens to know the nature of cataract, and look for any pseudo exfoliation material which is present on the lens or at the pupillary margin, as well as to know the type of cataract. And the next is fundus evaluation. So fundus evaluation is important to check, to assess the prognosis post surgery. So if the patient is diabetes, we need to look for any diabetic retinopathy changes or any hypertensive as such. Few age patients they might have, as cataract is a senile um, as cataract is a senile disease, they can have certain macular dystrophies, macular degenerations associated with it. So, detailed evaluation of fundus is also very important. Um, so, if the media is not clear in case of mature cataract, so we need to do other alternate tests like B scan or brightness scan, so which gives a rough estimate about the attachment of the retina as well as vitreous. So, followed by intraocular pressure measurement. So, preoperative evaluation is incomplete without measuring the IOP. So, there are different methods. The one shown in the picture is applanation type of intraocular pressure measurement. So, most commonly we use this is called Goldman's applanation tonometer, which is attached to the slit lamp. The other methods are Shiot's or Perkins, which is a handheld tonometer. So if you can see at the right hand side, you can see a fundus evaluation using direct ophthalmoscope as well as indirect ophthalmoscope. Left hand side, you can see a B scan ultrasound picture image. It's running at ultrasound image of the posterior segment of the eye. So you can see a rough counter of the retinal counter as well as the vitreous. And coming to biometry, biometry is performed to calculate the IOL power needed to so biometry is done to calculate the IOL power. So it includes both keratometry as well as A scan ultrasonography. So it is done A scan, basically it is done in two methods. One is contact method as well as immersion method. So in the right hand side you can see the keratometer. This is a Bosch and Long. There are different types of keratometers like automated keratometers, Bosch and Long keratometer, IOL master. Left hand side you can see a scan machine. This is a scan probe, which is a contact method which is being done. So this is essential to calculate the IOL power of the lens which has to be inserted during the cataract surgery. So the commonly used formula calculating the IOL power is SRK, which is named after three people, Sanders, Resloff and Croft. So the first letters of each one has been taken, and it's based on the regression analysis taking into account a retrospective analysis of a large number of post-operative refractions. So the formula is P is equal to A minus 2.5 L minus 0.9 K. This is very important. So P is the power of the IOL which has to be implanted. L stands for axial length in millimeter. K stands for curvature or keratometric reading or corneal curvature. A is a constant. It depends on the material of the lens which is being implanted. So there are other formulas. The standard formula is SRK1. There are different other formulas based on the axial length of the eyeball, like SRK2, SRKT, Hoffer Q and all. So this IOL biometry itself is a short question. So coming to systemic investigation prior to surgery. So basically we need to check for blood pressure if the patient is hypertensive. Lab evaluation includes like RBS, FBS if the patient is diabetic or not diabetic, also to rule out if the sugars are high, and only if required, if any respiratory problem, we need to go ahead with the chest X-ray, or if any cardiac problem, we need to go ahead with the ECG. Coming to preoperative medications and preparations, like tropical antibiotics such as tobramycin, ciprofloxacin, and quinolones for 3 days prior to the surgery is advisable as a prophylaxis against endophthalmitis, which is one of the rarest complication, and preparation of the eye to be operated. Previously, it was a must, trimming of the eyelashes, but nowadays many of the surgeons skip it because various studies have proved they don't have any role in trimming the eyelashes to prevent endophthalmitis. Like an informed and detailed consult, like any other surgery, informed and detailed consult has to be obtained, and scrub bath and care of the hair. So each patient should be instructed to have a scrub bath prior to the surgery, and if any beard and hair has to be trimmed prior to the surgery. And to lower IOP, we give acetazolamide, which is a carbonic anhydrase inhibitors, just before surgery, or 2 hours before surgery, or night before surgery. And if required, if the patient is having a high IOP or any other complications associated with cataract like meningitis, we need to give glycerol or IV mannitol. And to sustain pupillary dilatation, which is very important while performing the cataract surgery, we need to give indomethacin or flurbiprofen eye drops. And for dilatation, we need to use tropic acid plus eye drops, which contains both tropicamide and phenylephrine. And coming to the anesthesia, cataract can be performed under a local anesthesia and general anesthesia only in case of people who are not cooperative or mentally retarded, or any specific indications we need general anesthesia. Otherwise, usually it is performed under local anesthesia, and most preferably nowadays we do under topical anesthesia. And coming to types and techniques of cataract surgery. So the cataract surgery has evolved a lot over a time. So the initial technique which was performed years ago was intracapsular cataract surgery, and it has evolved over time, and now mostly we do extracapsular cataract surgery. And extracapsular cataract surgery is again subdivided into conventional ECCE, which was done previously and obsolete now, manual small incision cataract surgery, and phacoemulsification. Coming to intracapsular cataract extraction, so it involves extraction of the entire lens including the posterior capsule and zonules. So you need to note this down. So we are removing the entire lens along with the posterior capsule as well as the zonules. So this is not done regularly because this is not done nowadays because we don't have a support to place the IOL. So this is a surgery of choice only if there is markedly subluxated or dislocated lens where zonules are weak. We are not having any posterior capsular support to place the IOL. So only then we are doing this surgery. And this technique of surgery, like I told, has largely been replaced by extracapsular cataract extraction. So the prerequisite for this is weak and degenerated zonules, like in case of subluxated or the grossly subluxated or dislocated lenses. So like I told you, indication is subluxated and dislocated lenses. So you need to know the differences in technique of ICCE, conventional ECCE, SICS, and phacoemulsification. Like in this class, I'll be dealing with ICCE, conventional ECCE, and small incision cataract surgery. Coming to steps of ICCE, so I'll show you the picture. So So coming to steps of ICC. So the first is passing of superior rectus bridle suture. So it is passed. So it is done in all, like this is the initial step to fix the globe. So it is common for all the surgeries. So wherein superior bridle suture, like you see in the, which is mentioned as A, you can see a bridle suture which is passed to fix the eye in down gaze, followed by a conjunctival flap. So is prepared to expose the limbus, because conjunctiva is cut, that is conjunctival peritomy, or it is cut, and any bleeding, hemostasis is maintained by using a wet cautery. These are the steps which are common for all the three surgeries. So followed by a partial thickness groove is made through 2/3 depth of the anterior limbal area. So from 930 to 230, and with the help of a razor blade knife. So this is one of the difference between ICCE and SICs. So here a very large incision is made, that is from 930 to 230 clock position. So almost 150-degree incision at the limbus. The incision is made at the limbus, which is 2/3 thickness, 2/3 depth of the limbal area, followed by a corneoscleral section. The anterior chamber is opened. So this is the D shows with the scissor corneoscleral section, like we are cutting the incision whatever was made. We are using a razor, we are using a so we are using the razor blade knife, and we are cutting the limbal area, that is corneoscleral. We are making a corneoscleral section, followed by peripheral iridectomy. Peripheral iridectomy may be performed. See, we are holding the iris and we are cutting the Vanna scissors. Will cut a small part of the iris. So this is mainly to prevent post-operative pupillary block glaucoma, because the vitreous can come and block the pupillar area, which can lead to glaucoma. So we do a prophylactic peripheral iridectomy. So and followed by lens extraction. So in ICC, the lens can be delivered by any of the following methods, like cryo extraction or Indian Smith method. Here the lens is delivered with tumbling technique by using counter compression, or here what is shown is cryo extraction, where a cryo probe is used to remove the lens. The other one is capsular forceps method, wherein Argas capsular holding forceps is introduced close to the anterior chamber, and the anterior capsule of the lens is caught at 6 o'clock position, and the lens is lifted slightly and its zonules are ruptured voluntarily. Then the lens is extracted with gentle sliding movements. And another one is wire vectis method, wherein a wire vectis is used to slide gently below the subluxated lens where it is fixed and removed. So after the removal of the lens along with the posterior capsule, so the next step is formation of anterior chamber. After the delivery of the lens, iris is deposited into the anterior chamber with the help of iris depositor, and the chamber is formed. And followed by, since there is no support, posterior capsular support, so we need to place a anterior chamber lens. Since there were no iris clip lens or scleral fixated lens during that time, so they used to place mostly anterior chamber lens. Now if we have to do ICC in case of crossly subluxated or dislocated lens, we have different methods of IOLs which can be placed without the posterior back support, like iris clip lenses which can be clipped to the irises, or scleral fixated lenses which can be sutured to the sclera in spite of posterior capsule being absent. So followed by anterior, this is the anterior chamber IOL. So the shape of that, you can see there is a difference between the posterior chamber IOL and anterior chamber IOL. So this is also called Kenman flex lenses. So anterior chamber IOL is implanted, followed by closure of the incision. This is a very big incision. It needs to be closed by using sutures. So the things you need to remember in ICCE is the posterior capsule along with the zonules, everything is removed. The entire lens bag is removed, and a big incision, almost like 150-degree incision, like from 9:30 to 2:30 o'clock position. We are making a huge incision, and followed by anterior chamber IOL implantation. So this is ECCE. This is ICC. Now coming to extracapsular cataract extraction. In this you need to remember the major portion of the anterior capsule with epithelium, nucleus and cortex, everything is removed, leaving behind the intact posterior capsule. So hence allowing us to place a posterior chamber IOL. So this is the surgery of choice for all type of adulthood as well as childhood cataract, unless there is some contraindication like grossly dislocated or subluxated lenses. So types of, so like I told you, there is evaluation even in extracapsular cataract surgery also. So initially they used to do conventional extracapsular extraction, followed by manual small incision cataract surgery, and now most commonly what we are doing is phacoemulsification, which has again advances in which has again evolved over a period. Like there is a femtosecond assisted phacoemulsification is the most advanced technique, that is also called flax, that we'll be discussing in the later classes. So coming to conventional extracapsular cataract surgery, so here also you can just see the image. I'll be explaining based on this. So the initial steps are same, like superior rectus brittle suture is passed, and conjunctival flap is prepared to expose the limbus, and if any hemostasis is achieved using a cautery. And in case of conventional ECCE, a partial thickness groove is made through about 2/3 depth, similarly like ICCE, anterior limbal zone. So but the size is less, like it is done from 10 o'clock to 2 o'clock position, when compared to ICCE, which was 9:30 to 2:30 position, or 150 degree this one. So this is relatively a lesser incision, comparatively a lesser incision, with the help of similarly razor blade, and a corneoscleral section is made, which is done by a razor blade knife or with the help of keratome. And to maintain, and one thing is always we need to maintain the anterior chamber depth in case of cataract surgery, so to prevent damage to the endothelium. So as you know, endothelium doesn't regenerate. So during surgery, if we are manipulating and if we are touching the endothelium frequently, it can lead to endothelial decompensation post surgery, so which doesn't have any treatment, which finally ends up in corneal transplantation. So hence we have to be very careful while doing any maneuver. We need to maintain the anterior chamber by using a viscoelastic substance, which is mainly 2% methyl cellulose or 1% sodium hyaluronate is injected into the anterior chamber. So here the steps are from so initially what they have shown is a capsulotomy. So you can do a capsulotomy either in the beginning. Capsulotomy has to be done before doing the incision. Hence the anterior chamber will be maintained, and a proper capsulotomy or capsulorhexis can be done. So coming to capsulotomy, there are different techniques. One is can openers capsulotomy, continuous curvilinear capsulorhexis, and linear capsulotomy. So what they have shown in this picture in A, it's a anterior capsulotomy, wherein we use a irrigating cystitome or bent 26 gauge needle is introduced, and multiple small radial cuts are made in the anterior. You can see multiple small cuts are made in the anterior capsule 360 degree. So this is capsulotomy. whereas in case of linear capsulotomy, here a straight incision is made in the anterior capsule from 2 o'clock to 10 o'clock position, similar to the corneal incision, and the rest is completed in the end after the nucleus and cortex is removed. So the third one is continuous curvilinear capsular excess, which is most commonly done nowadays, because for phacoemulsification, a good round capsular excess is very important. So continuous curvilinear capsular excess, wherein there are no tags and a proper round capsular excess can be performed. So in this, the capsule is torn in a circular fashion, either with the help of cystitome or with capsular excess forceps. Uh, Following the removal of capsule, the next step is completion of the corneoscleral section. Like initially, the corneoscleral incision was done. Now corneoscleral section has to be extended. Like we need to complete the corneoscleral section using the enlarging scissors or a keratome. So this is the completion of the corneoscleral section using a scissors. So after this, hydrodissection is done. Hydrodissection is nothing but injection of BSS, balanced salt solution or lingual lactate, between the capsule and the under the peripheral part of the anterior capsule. So this separates the nucleus from the cortex and helps in prolapsing of the nucleus into the anterior chamber. So hydrodissection has to be done. See, if you see this image, the fluid injection is there. So it is done on the peripheral part of the below the peripheral part of the anterior capsule. So it goes and separates the cortex from the nucleus. So following this, okay, sorry. So this is a cortical wash. So they have not given hydrodissection here. So they have directly gone ahead with removal of the nucleus. So after hydrodissection, so the next step is removal of the nucleus. So it is done by different techniques similar to ICC, where we are using wire vectors or cryo extraction or different techniques. Here we don't do cryo extraction because we are preserving the zonules. Here the most common is irrigating wire vectors or sandwich technique, or pressure and counter pressure method. In this, the pressure is applied at 12 o'clock position with corneal forceps or lens spatula. Nucleus is expressed by counter pressure at which is extra at 6 o'clock position, and similarly by passing a irrigating wire vectors or normal wire vectors with a lens dialer above it, we can extract the lens. So this is a wire vectors. So there are two types, one which comes like a irrigating wire vectors with a fluid, so which the fluid itself will push the lens outside. The other one is using this wire vectors as well as a dialer over top of the lens by sandwich, like similar to a sandwich, like we are sandwiching the nucleus between both the instruments and removing it. So that is also one of the commonest techniques, sandwich technique. We usually perform that. And now what is left behind is the cortex, because by hydrodissection we have separated the nucleus and cortex, and we have prolapsed the nucleus and delivered the nucleus. The next step will be aspiration of the cortex. Like you can see here, we are removing the cortex which is left behind by using a Simcoe cannula, that is irrigation Simcoe cannula, with the help of a balanced salt solution. So we irrigate the fluid and aspirate the cortex. So once the cortex is removed, so next comes the implantation of IOL. So in IOLs also, IOLs itself is a big chapter. There are multiple advances in the IOL. So which was used previously, the standard one, or which we are using for camera setup and all, they are PMMA lens or polymethyl methacrylate lens. So this IOL is implanted in the capsular bag. So followed by, since this is also a large incision of about 120 degree, we need to again put sutures. So closure of the incision is done by putting sutures, like 3 to 5 interrupted sutures. So in ophthalmology we use a very thin material, that is mostly nylon 10-0. So you can imagine 10-0. Ideally for surgery and all, we'll be using 20, 30, 40 sutures. So 10-0 is a very thin suture, thinner to your hair. Okay, so wound is closed by 3 to 5 interrupted sutures, and the viscoelastic whichever is remaining has to be aspirated, because leftover viscoelastic can lead to raised intraocular pressure. Then the conjunctival flap is reposited. So similar to ICC, I'm not told these steps in ICC, so I'll be telling you. So the conjunctival flap is reposited, followed by subconjunctival injection of dexamethasone and gentamicin has to be given. Subconjunctivally we need to inject dexamethasone and gentamicin. This is as a prophylactic measure to prevent post-operative infection, like I told you, to prevent post-operative endophthalmitis, and eye is patched. So both in ICC and ECC we need to. So you would have noticed the differences between ICC and ECC. The main difference is here we are preserving the posterior capsule. So the first difference will be the length of the incision. Then the first is the posterior capsule is left intact. Then the length of incision is comparatively smaller. Then because the posterior capsule is left intact, so we are doing hydrodissection and prolapsing the nucleus, removal of the nucleus, followed by cortical aspiration, then putting the IOL into the bag. So whereas in case of ICC, so we are not preserving the posterior capsule or zonules, so directly after the conus clearance incision we are pulling out the entire lens with the bag. Hence we are doing very crude techniques, putting wire vectors below the posterior capsule, using a cryo probe or Orgas needle to extract to weaken the zonules and extract the lens. And we are putting a anterior chamber IOL or different IOLs which doesn't need posterior capsule support, like iris clip or scleral fixated lens. So coming to manual small incision cataract surgery, so this is most widely done. Other than phacoemulsification, this surgery is most widely done nowadays for camp setups and all. So coming to steps in small incision cataract surgery. So here the initial steps are similar, like superior rectus brittle suture is passed, and conjunctival flap is raised, and hemostasis is attained by using a wet cautery, then followed by incision. So here the most important thing what you need to note is we are not making a limbal incision. We are not doing an incision at the limbus, unlike ICC and ECC where we used to do a limbal incision. Here we are making a scleral incision. So the incision is done approximately 1.5 to 2. Here you can note the incision is made 1.5 to 2 millimeter away from the limbus. So and the length of the incision here it varies from around 5.5 to 7.5 mm, unlike the ECC and ICC where we are approximately making around 8 to 10 centimeter incision. Here the size of the incision is smaller. So as the cataract surgery has evolved, the size of the incision has reduced a lot. In case of ICC it was a very large incision, and ECC reduced by 30 degree almost, like. Then compared to SI, then coming to SICS, it's a smaller incision, 5.5 to 7. Coming to phaco, it's around 3.2 millimeter incision, and now they are working on a lesser incision size. So the main point in reducing the incision size is to reduce the astigmatism caused by wound healing. So if we are making an incision, it leads to scarring, and healing of the healing of that incision will lead to astigmatism. So followed by poor visual prognosis post surgery. So the decrease in the incision size has good result by reducing the astigmatism post surgery. So the scleral incision. So the initial steps in SICS, small incision cataract surgery, are similar, like I told you, and after the incision is done in sclera, the scleral tunnel is made 1.1 to 1.5 millimeter from the limbus, and after the incision, a corneoscleral tunnel is made with the help of a crescent. So a crescent knife, so you can see a crescent knife is passed, and a sclerocorneal, along the sclera it is swept and it has entered even into the cornea. So hence we call corneoscleral tunnel, which extends 1 to 1.5 millimeter into the cornea. So followed by this is a tunnel. We are not entering into the anterior chamber. This crescent plate, it has a blunt end where only it has a side cutting edges, and it won't enter into the anterior chamber. We are just making a tunnel. So followed by this, we are making a entry into the cornea with the help of a keratome. So internal corneal incision, basically it is done with the help of a keratome, which is a diamond shaped blade which has a sharp cutting edges and a pointing tip. So this dimension is important because in case of echoemulsification, we just do one entry with this keratome and we do the procedure. So you can know roughly this 3.2 millimeter. So the incision in echoemulsification will be 3.2 millimeter, and they're working out on reducing the incision. That is different thing, but you need to remember the size of this keratome blade is around 3.2 millimeter. Then after entering, we can make a side port at 9 o'clock position. So this is mainly, it helps, we are making a, see you can see in H, you can see a small side port entry blade entering, and we are making a side port. This mainly helps in removing of the cortex in the subincisional area, in the superior part, because irrigation and aspiration, so we can remove the cortex throughout the this one, but subincisional cortex, it is difficult to remove with the help of a synco. So with the help of side port, it will be very convenient to remove the cortex in subincisional area. So that's an reason for side port. And followed by, so the next steps are similar to conventional extracapsular cataract surgery, like we do a capsulotomy or rhexis, anything. So here what you're seeing is a continuous curvilinear capsular rhexis. So we are seeing the flap, a circular flap which is being raised and which is turned. So followed by capsulotomy or rhexis. So we need to do hydrodissection, similar thing like ECCE. We need to inject a balanced salt solution or lactate, which is it is essential to separate the cortex from the nucleus. So followed by that, we are using a hook to prolapse the nucleus into the anterior chamber. So this is a IOL dialer or Sinski hook we call. So we are prolapsing the nucleus into the anterior chamber, followed by the removal of the nucleus. So similar to ECC, we use irrigating vectors or sandwich technique, wire vectors with the help of Sinski hook above, by sandwich method or a counter pressure method. Anyway, the nucleus can be removed. So these are the multiple techniques like irrigating vectors method, phaco sandwich technique, Blumenthal technique, phaco fracture, like making it into multiple fragments and removing. So there are multiple techniques to remove the nucleus. You just need to know the name. And the most important technique what we use is a sandwich technique, wherein we place a vectors below the nucleus and a IOL dialer or Sinski hook above the nucleus, and we sandwich the nucleus and remove it. So That is the most common method. Then followed by cortical wash. After the nucleus is removed, the remaining cortex has to be washed. Here we are doing a cortical wash, followed by implantation of IOL into the bag and dialing the lens. So similar to ECC, removal of any viscoelastic has to be removed. And the difference between ECCE and this is we are not putting sutures at the end of the surgery because it's a self-sealing wound. So here the wound incision length is small when compared to ECCE, and we are making a scleral tunnel, so a corneoscleral tunnel which has properties of self-healing. So it's a 3 planar incision. We are making an incision with the sclera, then we are making a tunnel, then we are entering into the anterior chamber. So it's a 3 planar tunnel, and it has property of self-healing, and we need not put the sutures. And just approximate the conjunctiva, give a subconjunctival injection, and patching of the eye is done similar to ICC and ECC. So coming to the differences between ICC and ECC, in ICC we have a large incision, like I told you, around 10 to 12 millimeter, whereas in case of ECC, this is mainly small incision cataract surgery that I mentioned. So it's not 5 to 6, it's approximately 5.5 to 7.5, depends on the hardness of the nucleus. So in case of conventional ECC, it is more, but just to remember, in ECC, the posterior lens capsule, it's not lens, it's a posterior lens capsule is preserved, whereas in ICC, the entire lens is removed, and in ECC, no stitches are required. It's a self-healing incision, whereas in case of that too, it is small incision and phaco. It's not the conventional ECC. They're mainly speaking about a manual small incision and phaco. No stitches are required. It is self-healing. And in ICC, we require stitches, and we have, because of that, we have long rehabilitation time. In ECC, we can place the IOL into the bag, whereas in case of ICC, we can't place IOL into the bag either. We have to put an anterior chamber lens or other different type of lenses, or we have to give an aphakic glasses like which they used to do previously. And post-operative complications in ECC are comparatively minimal when compared to ICC, because ICC there is more vitreous prolapse because we are removing the posterior capsule, so the vitreous will come into the anterior chamber, more chance of retinal detachment, corneal edema, and vitreous loss is more in case of ICC. Thank you.